Good afternoon and welcome to our webinar about building on value-based healthcare towards a health system perspective. Now, the pressures on health systems were thrown into sharp relief by the COVID-19 pandemic, and the need for health systems in Europe to become more effective, accessible and resilient is even greater now. Value-based healthcare is increasingly being used to promote the transparent use of available resources to improve health outcomes, patient experiences, and the efficiency of care. Now, from a health system perspective, value embraces health improvement, healthcare responsiveness, financial protection, and efficiency and equity to look towards contributing to societal well-being. The focus on outcomes centres what matters most to citizens and patients, shifting the focus from health to well-being. Now, this is a relatively new change in emphasis, and the policies and programmes implementing value-based approaches are similarly novel. So it is really exciting to explore this topic with you today, right at the cutting edge, to find out more about value-based healthcare as an idea and also in practice. Now, we have a great panel of speakers today to explore this topic. First up, we have Professor Luigi Siciliani of the University of York in the UK, who worked on the policy brief and related paper, which just came out in Health Policy. It's open access, so you can all read it without any barriers. Now, Luigi is a professor of health economics, and he's a former member of the European Commission expert panel on effective ways of investing in health. And he will be pulling together different approaches to value-based healthcare so that we all have an overview of the field and the policy levers identified so far. We then have two excellent spotlight speakers who will be taking a closer look at some practical examples. We have Anna Kråwinkel, who is Head of Research and Deputy Secretary General at the Swedish academic think tank Leading Healthcare. Now, Anna will zoom in onto the experience in a few hospitals in Sweden, where they experimented with putting value-based healthcare into practice with very interesting results that have lessons for all of us. And next up, we have Christian Newman, who is National Allied Health Professions Advisor for Value-Based Healthcare with the Welsh Value in Healthcare Centre, and Deputy Head of Value-Based Healthcare in the Hywel University Health Board. Now, Christian will be describing exciting new developments in Wales, creating a new pathway for value-based healthcare across the life course. Now, as ever, we will then have plenty of time for your comments and questions from the chat box, so please do not be shy. Ask your questions, and we welcome your comments, insights, and country experiences too. Now, the chat box today will be moderated by my wonderful colleague, Nicole Mauer, who will now introduce a poll question for you all, so we can have a little bit of an insight into your thoughts out there in the audience. So, Nicole, over to you.
Thanks, Erica. So we've prepared two questions for you today to get us started. The first one is a very simple yes or no question. And we'd like to know whether value-based healthcare has been is well established in your country. The second question is, which is a multiple choice question, so you can select one or more options, is which aspects of health system value should be the key focus for value-based healthcare? Should it be health improvement, healthcare responsiveness, financial protection, efficiency and equity, or indeed none of the above, or all of the above? So I'm looking forward to seeing what the results will be and what your inputs are, but for now I'll hand back to Erica. Thank you.
Thank you very much, Nicole. Okay, so we will give you time to answer the poll, and Nicole will come back with the results after Luigi's presentation. So without further ado, I would like to hand the floor to Luigi Siciliani of the University of York. Luigi, over to you.
So thanks for the opportunity to talk about value-based healthcare and how to make it work for health systems. So the first thing when you think about value-based healthcare is, what is value in value-based healthcare? What is your definition of value? And this is where many people have different views and they interpret value in a very different way. So we defined value as a health system value as the contribution of the health system to societal well-being. So that's our definition of value, as it is societal well-being. When I say we, I put my co-authors' pictures here. So it's Peter Smith, Anna Sagan, and Joseph Figueras. So when Joseph asks us, how should we make value-based healthcare work and what should be the notion, for us, this was like a natural choice. Why was that the case? So I think having value as societal well-being has two main advantages. One is that, first of all, is a unifying concept, or even in a simpler way, it's one concept. So if you have many different concepts around value, that's more difficult to operationalize. To have just one concept and say value is well-being, that simplifies things in some way. The second reason why we also like this notion is that if you think about the many health system objectives, the traditional health system objectives that were mentioned in the poll, and I hope that you all answered that all of the domains were the correct, were included in value. So what we can do is to map the traditional health system objectives into societal well-being, and that's the first thing I'm going to show you. Once you have, if you agree with that notion, then you can use to make this operational. Then you have to go to the next step and say, well, how are the different actors of the health system contributing to the health system objectives, which in turn affect societal well-being. And once you have actors and health system objectives that are all unified through societal well-being, then you can use a matrix of actors and objectives to assess how specific action or policy levers are contributing to societal well-being through the different actors and through the different objectives. So I'm going to go through these 3 points in turn quite quickly. So the first point is to explain, is to show that, or try to convince you that well-being can encompass the traditional health system objectives. So we know that health, if you provide healthcare, this improves health, which is a key determinant of well-being. But that's not the only determinant. If you think about non-health determinants that from healthcare, patient responsiveness, how the patient was treated, whether the patient was treated with dignity, and many other non-health dimensions, those all can contribute to well-being. Then you can think about financial protections. So financial protections can give ex-ante reassurance to individuals, to citizens, that they will be taken care of if they fall ill. So that's the ex-ante reassurance. And then ex-post, once if some of them they will fall ill, financial protection will avoid that patients have catastrophic payments or have high out-of-pocket payments. So again, you can see why these are key determinants of well-being. Then you have vertical objectives like efficiency and equity. We want healthcare to be provided efficiently because those resources could be used for other services or goods that also affect well-being. It's not only health that affects well-being. There are also other consumption. And then equity also can be fit into the concept of well-being. Different distributions of health and different distributions of well-being across individuals that will affect the societal well-being. And then the last bit I'm going to mention is about co-benefits. So if you're thinking about the effect of a health system outside of the health sector, if you think about the effect on labor market outcomes, whether people can go back to work more quickly, that can also fit under well-being quite easily. So in that sense, I hope that I've tried to convince you that if you equate value as well-being or societal well-being, this can accommodate a large set of traditional health system objectives. Once we have clarified that, we can move to the next steps. Again, if we want to try to operationalize, then we can think about the actors. We know that there are different actors in health systems. You have national policymakers, you have purchasers, provider organizations and practitioners, citizens and patients, and each of these actors have a key role in improving the value of a health system. So if you think about national policymakers, first of all, they are the one in charge of providing a definition of value, and then they have an important role in designing the rule of the games and the policies in the health system. Purchasers can also contribute value in a different way by choosing the right mix of healthcare services that's related to allocative efficiency or the basket of health services that they provide. Provider organizations and practitioners, they have an immediate role for providing the health services that will improve health and responsiveness, but they're also in charge of the resources. So that also affects the efficiency of the system. And then citizens and patients, they also have a role. The citizens, through the electoral process, they can indirectly influence the financing of the health system, but they can also affect the health system and create values by having more healthy behavior. And in some cases, if you think about patients with chronic conditions, also they can be co-producers of their health benefits. So that's the second step. Once you have done this second step, then you can think about policy levers. So again, this is like more trying to provide a framework to think how policy levers can be seen through this lens. So we have actors on one side, we have a health system objectives. So what we have done in the health policy brief, and I'm not going to go into any details, is to map many policies like universal health coverage, strengthening primary health care, pay for performance, and try to map them through this matrix of actors and health system objectives, and try to identify how each of these policy levers can generate value or well-being by hitting these health system objectives through the different actors. So that's how we organize our ideas around value-based healthcare. Okay, so let me conclude with some key messages. So value-based healthcare, if defined as societal well-being, can be used as a unified guiding principle. So I don't think value-based healthcare will solve all the problem, but I think it can be a useful tool to organize ideas. It can be more prominent. So well-being could be, there is quite a lot of discussions around well-being, but I think the way I see and read some of the health policy document, well-being as a guiding principle could be more prominent. So that's the second point. The third point is that well-being is a quite flexible concept. So it can allow for health benefits, but also non-health ones. If you think about responsiveness and co-benefits that health system can generate outside of the health system, other sectors, that can also be fit in. And then my last point is that value-based healthcare is compatible both with performance measurement, but it doesn't. So it can be with measurement, but it can also be without measurement. So there a lot of discussions around value-based healthcare have been around measuring benefits and measuring cost. So that's one purpose. And as these indicators develop, I'm sure that the health system will use them with or without maybe some competition elements, as it has been used in some other frameworks, but it can also be used at a conceptual framework, even if we will never be able to measure all dimensions of performance in a health system, but we can still use this framework of well-being across different actors to guide policy design. So just again, to summarize, I think value-based healthcare can be a useful tool to organize ideas and promote efficient investments in the health sector. Thanks a lot for listening to me, and these are the sources of my talk.
Thank you very much, Luigi. Very interesting summary there, and already some debate kicking off in the chat box, I see, which is very exciting. So it'll be very interesting to see how value-based healthcare has been operationalized already in the two case studies that we've got today. But before we leap ahead with that, Nicole, I need to ask you about the poll.
Yes, so we've got some interesting results. Surprisingly, or perhaps not, the majority of respondents replied that their countries do not have well-established value-based healthcare yet. In terms of question 2, we have a clear forerunner, all of the above. So it looks like people have read the policy brief, or at least, anticipated what Luigi was going to tell us today. But we have some runner-ups. So health improvement is in second place, and then efficiency and equity, and then closely followed by healthcare responsiveness and financial protection. So yeah, back to you, Erica.
Thank you very much, Nicole. Okay, so without further ado, I would like to leap over to Sweden. So Anna Korvinkel is going to tell us about the experience there. Please do, Anna, go for it.
Yes, hello everybody from Stockholm. Thank you for this opportunity of sharing a little bit of our insights on value-based healthcare in Sweden. I should say directly in relationship to Luigi's excellent introduction here that what we studied in Sweden was an attempt to implement Michael Porter's concept of value-based healthcare, and also not all of it, but specifically the components that adhere to what is done at the operational level by providers, and specifically in specialized healthcare in Sweden, that is the university hospitals. So when I will be talking about value-based healthcare in the Swedish experience, it's more from the viewpoint of Michael Porter's model and his concept of value, which is, the equation that you maybe all know or have already forgotten, healthcare outcomes over cost, basically. And what the Swedish university hospitals tried was to implement this between the years of 2013 and 2017, more or less, and with a focus on organizing care in better flows and to measure outcomes in a more bundled way for those care flows. We studied this process of implementation at 3 different hospitals. There were some differences in the process, how the concept was introduced, how much the doctors were involved, and how much it was consultancy driven, and a few procedural issues that were different, but in content it was highly similar, with the focus of organizing better patient flows, shorter time spans, but also more efficient allocation of resources like localities and so on within the hospital. And what we found was that the introduction of this version of value-based healthcare was very much closely tied to earlier quality improvement work, focusing on patient flows. That is concepts like lean and episodes, various quality work, focusing on time and reducing waiting times and making smoother, patients passing smoother from step to step in a care process. So in that respect, value-based healthcare was really nothing new, although it was introduced as something that would revolutionize the working of the hospitals. But in practice, it was very much tied to earlier experiences with quality improvement work. And also our conclusions, or the takeaways, are tied to this realization that this version of value-based healthcare, Porter's model, fits very well with the easily defined elective care processes, where you have a clear beginning and an end, and the patients are, to say that they are easy patients is the wrong word, but they are not complicated, often in the sense that they don't have multiple diseases and so on. They have one condition to be treated in a clearly specified flow. It didn't suit that well when they tried to implement it for more complex care flows, for patients with multiple conditions or patients that need both healthcare and social care. This measurement model simply didn't work out as well. And also the organizational reform that was tried to be made to organize the whole hospitals around care flows really didn't show any signs of improvement of efficiency of the hospital as a whole during the period that we studied it. It might be that after a few years, some investment costs might equal out and the picture be better, but in our study we could not show any such effects. We also concluded that a feature of the implementation process was decisive for how the success or failure was perceived, especially in one big hospital in Stockholm. The consultancy involvement was not perceived very well by the medical profession, and in fact, that kind of labeled the whole experiment as a failure, more for procedural reasons and lack of trust than from failure of the measurement model and the organization model in itself. So at those Swedish hospitals, this version of value-based healthcare led to more measurement and standardization. It did not lead to those different mechanisms of competition that Porter also described, where a whole country will start working differently simply because it wasn't implemented at the policy level, and it wasn't implemented at the purchaser level, but only at the provider level. So it's not surprising. And one additional finding, which is interesting also in the relation to expanding value-based healthcare to be something more than what Porter envisioned, is that now several hospitals are working with more qualitative patient involvement in how these care flows should be organized from a patient perspective. And they have integrated that into the value-based healthcare work. Despite not actually being part of the original model, that component of introducing the patient perspective and what should be measured and how flows should be organized is a positive takeaway that I think has been more long-lived than, for example, the use of this the Porter equation for describing health value. That was my short presentation.
Thank you very much, Anna. Thank you. So yes, very interesting. So it's we're moving into the application of value-based healthcare and the ways in which it has been conceptualized and defined, and then how do you make it sort of more concrete, and the challenges around combining it with things like integrated care, and of course, always the essential need to, with changes in hospitals and the way they're organized, to take the clinicians with you. So thank you very much for that insight. Now we're going to look to the future with Wales. Christian is going to talk about some new innovations that are going on and just being implemented there. And hopefully these will sort of help to shape our understanding of value-based healthcare. So Christian, over to you.
It's lovely to join you all today. So I'm going to be talking about value-based healthcare in Wales, and I thought I'd start with providing a little bit of context. So in Wales, the Welsh Government sets the strategy for delivering healthcare services. And when the Welsh Government produced its strategy, which is called A Healthier Wales, back in 2018, it included the internationally renowned quadruple aim as the central idea to drive transformation across the health and social care system. However, it adopted the model to suit the Welsh context, and it replaced the theme that is often labelled lower cost with higher value health and social care, demonstrating really the Welsh Government's commitment to a value-based healthcare approach. So we are really fortunate in Wales that we have this and a number of other policies advocating a value-based healthcare approach. But how do we deliver value-based healthcare in Wales? Well, there are 7 integrated health boards in Wales, and what I mean by integrated is they are responsible for planning, securing and delivering healthcare services for their population, including both primary and secondary care. But how do we look at value in an integrated healthcare system? Well, what we've done in the National Value-Based Healthcare Programme is we've produced this generic model that you can see at the bottom of the screen. to encourage different parts of the system to consider the whole pathway, right the way from prevention through to end-of-life care. And you'll notice there are deliberately no service areas listed, and it's not broken down into primary or secondary care, because we need to encourage integration and collaboration across the pathway to produce the best possible outcomes for patients. And we use this model to consider what interventions are needed across the pathway and consider what high value looks like. So what does this look like in practice? Well, here's an example for heart failure, and you can see the required high value interventions at each stage of the pathway. So for example, in terms of prevention, we need to think about how we manage cardiovascular risk factors such as hypertension. But we also need to ensure we've optimized acute coronary syndrome pathway to reduce the number of patients that go on to develop heart failure. And then in terms of early accurate diagnosis, we need to make the best use of resources we have available and screen people using NT-proBNP blood testing prior to echocardiography, and make sure that we're only referring people for echocardiography to differentiate their symptoms if they absolutely need it. So where we've done this in Wales, we've seen some fantastic results, and we've been able to reduce time to echo, for example, which is a scarce resource in Wales for various reasons. And it means people are spending less time in ill health and are less likely to be admitted to hospital with an acute heart failure episode that has a significant mortality. However, we do need to build on these pockets of good work and drive whole pathway change across Wales. So what we're doing at the moment, we're currently developing a number of measures to drive specific improvements across the system. And here are some examples of the measures that we are currently thinking about for heart failure. And measures will span the whole pathway from primary care, for example, with the prevalence and management of hypertension, to secondary care, demonstrating a whole system approach to improvement. Now, it's a very exciting time in Wales because last year, the organisation that you can see in the centre of this diagram was introduced, which is the NHS Executive. And this was in response to an OECD and parliamentary review. And the NHS Executive brings together various national programmes, and its purpose is to provide a central guiding hand, working in partnership for and on behalf of the Welsh Government and in and with the NHS in Wales. Now, the National Value-Based Healthcare Programme formally moves into the NHS Executive in April, but we've been working very closely with them and the Welsh Government already, and we are in the process of developing 5 high-value pathways and the associated metrics, like the heart failure example that I mentioned earlier. And these pathways are going to be put into an integrated planning framework, which is issued annually to health boards by the Welsh Government. Now, traditionally, the integrated planning frameworks predominantly had time-based measures like referral to treatment or emergency department wait times. And whilst these measures may be important, the inclusion of the high-value pathways and the associated metrics signals the Welsh Government's commitment to value-based healthcare. And health boards will be required to report their performance against the various value metrics to the Value and Sustainability Group at Welsh Government. And that group used to be called the Use of Resources Group, but has been renamed, which again, I think signals the Welsh Government's commitment to a value-based healthcare system. So we really see this approach that I've outlined as the mechanism to drive whole pathway change across the system in Wales. Thank you.
Thank you very much, Christian. Thank you. Right, so we've had fantastic timekeeping from our speakers, I'm pleased to say. So we have plenty of time for debate, which is good because it's been a very, very lively chat box. So, Nicole, you have the joy of summarising some of the questions that have been coming in from the chat box. Please do keep your questions coming in. Hopefully we'll have time for another round of questions after this. So, Nicole.
Thanks, Erica. So yeah, we've had some very interesting and lively inputs in the chat. So to start off, something that's come up consistently is the definition of value. So one comment related to the fact that health systems are objective, which were mentioned in Luigi's presentation, so health improvement, financial protection, responsiveness, they also closely relate to performance. So how do we differentiate between these two different concepts? And again, in relation to definition and in framing the concept of value, another participant highlighted the importance of a common taxonomy. And so the question of, do definitions matter? Do we need to be very clear and reach a common understanding of what we mean by value-based healthcare and how we frame it? Another concept that came up related to the importance of outcomes, particularly patient outcomes, and over the entire patient pathway. So for our practical examples that we've heard from, so perhaps we'd like to reflect on the importance of patient outcomes and how patient involvement is ensured when we think about implementation. So I'll start with those, and then if we have time, I'll do another round. Thank you.
Thank you very much, Nicole. So yeah, quite big questions. So what is value and who is the value for? Is it value for patients, value for the health system, value for the economists, value for society? So yes, shall we start with Luigi for the conceptual overview?
Yes, thanks for those questions. So I've written out some notes. So starting with the performance question, I mean, there are lots of discussions around performance, and the main distinction there is, well, there is like lots of work from the observatory, for example, of health system performance. That's one dimension of performance. But then, you know, maybe in the Porter, more like a kind of thinking, you have provider performance. That's quite different performance. But the performance to me is just like, okay, you are assessing either the health system or a provider along some metrics. But if we don't agree on the value of those metrics, then in that sense, these concepts are connected, but they are also distinct. So in that sense, to me, the value-based healthcare potentially can be a little bit more enriching relative to performance. This is not to say that we shouldn't use performance. We use it all the time. And actually, that's one of my main points, is that you know, value-based healthcare is a way to organize ideas. We'll still continue to do performance assessment. We'll still do the many other policies that have been mentioned. Now, if you think about coordinated care, integrated care, patient pathways, you know, whether we agree or not on our definition of value-based healthcare, we'll still try to pursue those policies. So in that sense, yeah. So to me, performance is not incompatible with trying to come up with a definition of value. Now, on the definition of value, we thought that it was useful to have a definition that is at the health system level. I don't think this is incompatible with other definitions, for example, with Porter's definitions. If you think about European health system with public funding, I think this notion of health system value can be useful, and it doesn't have to be incompatible with the one by Porter, which is more within the private health US private health insurance system. But it's also important to define value, also to distinguish from other quite close terminology. If you think about other discussion where it is used value-based pricing, which you can interpret as a way, to charge a very high price because the value is so high. We have to be quite careful to make sure that we have a definition of value-based healthcare so that it is not confused, for example, with value-based pricing. I think I'll stop there. Thank you.
So, Anna, as someone who's been sort of like evaluating the impact of these policies, is there anything you would like to add?
Yes, thank you in particular for the questions on patient involvement and this concept of patient-reported outcomes and what value is actually measured. Actually, that was a very intriguing question to study because it's true that Porter's model mentioned that what should be measured is what matters to patients. But then on the other hand, when it was implemented in practice, what was used was often standardized sets of measurements actually produced by the Action Foundation, which some of you might know. And those measures some patient-reported outcomes, but based on an assumption of what would in an ideal case matter to an average patient. And the Swedish experience, I think, was that was interesting, but maybe not enough to really improve the flows in each local site. So what they did, in addition to using those standardized measurement sets, was to have a very qualitative work with patients sitting in the same room as a doctor and talking about how they experienced their journey and their treatment and so on, and maybe not always leading to other measurements that suit everyone, but giving this really qualitative perspective of what value can be for individuals, and also leading to changes maybe in more qualitative aspects of how to be received and how to be treated as with dignity, as was mentioned before, and so on. So I want to distinguish between those two, the standardized way of measuring patient-reported outcomes and the qualitative work of listening to patients' actual experiences. I think those two can complement each other well.
Thank you very much. Thank you. That's really, for me, as someone who sort of like skirts around health system performance assessments, of the idea of incorporating qualitative data into that is very exciting and terrifying. So, Christian, over to you. Is there anything you'd like to add?
Yeah, and just picking up on Anna's point, actually, I think we must always remember that the idea of this is to improve outcomes for patients and outcomes that really matter to patients. But I think we must be conscious that some of the processes within the system is what determines that outcome. And I think Luigi's point earlier about the importance of agreeing appropriate metrics that we measure. So, what does high value look like, and what does it look like across the whole pathway of care? And this is something we sort of grappling with at the moment, is trying to define what we measure at each of the different stages of the pathway, and which ones we particularly focus on, because I think traditional performance metrics in the health system sometimes have created some sort of perverse behaviours in the system. I think value-based healthcare gives us a different lens to look through and to make sure we focus in on the outcomes that really matter to patients, and really think about the metrics that drive those outcomes and the processes that drive those outcomes across the whole pathway of care.
Thank you very much. So, Nicole, I've noticed there's been more activity in the chat box. So, could you summarise what the next round of questions?
Yeah, so people have been responding to some of the feedback that we've been getting from the panelists. So there have been some follow-up comments on the patients and the need to ensure that we talk about people as well rather than patients. So ensuring that people remain healthy and do not become patients in the first place. We also have some comments on value, as the definition of value and Porter's concept of it, and that it might be too narrow. And so a follow-up question was, how has this concept evolved over the years? And is there a feeling that value-based healthcare is losing momentum, or is that just a sense that some people are getting in some national settings? There's also a question concerning differences on how it's implemented. So can we see differences in terms of how it's implemented in European countries compared to countries like the US or in the Asian continent? And what should be the priorities to ensure value in different areas of the system? So if we're talking about a health system perspective, rather than just focusing on a narrow definition of that, how do we ensure value in public health services and in different healthcare specialties? And then interestingly, we also have some respondents from countries that are trying to implement value-based healthcare, or they've done this in the past. So we have colleagues from Estonia and Poland, and there was sort of perhaps an interesting question related to that would be based on the experiences that our experts have had of implementation. So if one of these countries came to you to ask for advice on how to make it happen, what would you say? What are the biggest takeaways? What are the biggest positive and negative experiences of implementation? So yeah, this is another round, and I'll go back to the chat and see if there's anything new.
Okay, thank you very much, Nicole. Right, plenty to play with there. Luigi, over to you. How has it developed? What has changed? What's new? What are the side shoots, the offshoots from the Porter's definition? And have we moved on from there, or is it all still relevant and you're just broadening the church?
Yeah, I mean, just to provide a couple of thoughts. I mean, I don't follow all the detailed developments, but just there are like a couple of points that seems important to me. Well, one is about the measurement. So if you think about PROMS and PRESS, which the patient-reported experience and the health outcomes, these are quite prominent in the Porter value-based healthcare, but they're also prominent regardless of Porter suggestions. So in that sense, in some way, Porter suggestion reflects many things that had been going on in the health systems. So at some level, I think we are having too many parallel discussions where we want to say, oh, do we use this approach or do we use this other approach? But actually, we are all trying to tackle exactly the same issues. So I think we should try to find ways to unify these debates rather than kind of polarizing them. So in that sense, again, taking the PROMS and the PRESS as an example, these can be tools to improve quality and reduce cost. Then how exactly you do it? European health systems differ quite a lot. Within publicly funded system, you have more competitive system. Is compatible, has been compatible in the past with publicly funded system. I'm not so sure whether the competitive system within public sector has worked or has helped a lot. But I think the idea of using these performance measures seems obvious that we're going to use them. Once you have the technology, we're going to use them. Whether you use them to stimulate competition or whether you're going to use pay for performance or whether you're going to use public reporting. Again, I'm trying to make the point that we are having all these parallel discussions and we are trying to tackle the same issues. The main point is to try to come up with good policies that will stimulate quality, will reduce cost, and they will make use of these metrics. So that's one point. The second point is maybe related to well-being, and maybe why we think that this is like a good notion for the health system level, but people don't have to agree with us. But the point I want to make is that there are lots of policy discussions around well-being. So in that sense, why are we not connecting the dot? One day we have this big debate saying well-being is a great concept, and another day we say value-based healthcare is a great concept. But what's the difference? It seems that using value, well-being as an encompassing value. I mean, well-being can include the cost as well, because if you think about the resources you're using for the health system, and if you're able to reduce waste or reduce inappropriate care, which this comes up in any policy discussion, then you are freeing up resources for other goods. So you can bring value and well-being in that way. So I think those are my two main points I wanted to make.
Okay, thank you very much. So we're getting shortish on time. So I'm going to, please do feel free to answer any of the questions that Nicole summarized. But what I'd be particularly interested in, and I think a lot of the people in the audience would be, if you were to give advice to Poland, Estonia, some of the other countries that are here in the audience, what would you recommend? What would you advise? How do we put the patient or people at the center? How do we make this a well-being focused thing? Anna, Christian, who wants to go first? Anna, you're smiling.
Oh, very difficult question. I'm seeing that many of the questions in the chat also relate to this question about how to define value, how to expand it from Porter's model, how to avoid focusing too much on some components, maybe of Porter's model, like the cost issue and so on. that might balance out some of the other values and so on. And I think what we're discussing now in the expanded concept of value-based healthcare, and also when I see the Wales experience, is much more of an integrated view of what health is and what health care should be in society in general. It's moved very much to the almost a policy level question of how to connect better different parts of the system, including social care and so on. And I think that is a good movement, whereas what we studied was very much the opposite. This was focused on specialized care and how to improve actually small bits of care process to make them more efficient, which is a traditional way also of developing healthcare. But the discussions that we see now are much more on a broader societal level. And I think if that is actually not far from the discussions being carried out in Sweden today too, although we might not use that concept, which is a framing issue because of some of the quarrels in the hospitals before. But yeah, those discussions are central to any publicly financed, not only healthcare, but well-being system as a whole, I think. So my advice would be if to Sweden, if we would carry on again to go more from the top, the policy thinking, rather than from the nitty-gritty small details and how to measure specific care pathways and so.
Okay, so we should be bold, we should be going large, and we should be not getting too hung up on the labels. Think about the contents of the policy rather than the labels. Okay, so Christian, as someone who's in the thick of it right now in Wales.
Yeah, I absolutely agree with that. I don't think we should get too hung up on the definitions. I think it's useful to think about value-based healthcare as a philosophy rather than a sort of strict methodology in terms of how we're going to bring this change about. And some key lessons for us, I think, is this is very much a cultural change that's needed within healthcare. And we very much started off with a sort of grassroots movement with a bottom-up approach to value-based healthcare. And I know I've talked about sort of the policy implementation and how we're looking to do that today. But I think it's about then bringing both of those together. And I think if you have a too top-down approach, that won't necessarily work. I think you need to get both to meet in the middle. So I think that's really important. And I think the value-based healthcare helps us to look at what resources actually do we need to achieve high value, to achieve the outcomes that really matter to patients across that whole pathway of care.
Yeah, putting the patient at the center, or putting the people at the center.
Yeah.
Thank you. So Nicole, we have time for one more question, just one. Make it a good one.
Only one, Erica. That's
only
difficult.
one.
Can I just say that one of the colleagues who's been working on value-based healthcare has also posted their advice and said that it's important to focus on system design and to start from the expected health system outcomes and do a redesign of the whole system. So thinking about the importance of transformation and how to reach that. So a last question perhaps relates to evaluating value. So what's the importance of data in doing this? How do we measure and evaluate value for different actors? So we said that there are different actors involved, but how do we make sure that their perspectives are taken into account, and how do we evaluate this?
Well, big question to end on. Okay, metrics. I'm going to start with you, Luigi, because that's one of your favorite things in the world. So please.
Yeah, so I had a couple of points I wanted to make that is connected to this last question. So I think we should keep well, my first one is that we should keep all these exciting measurement developments on metrics and on quality and cost, because this we're going to make use of them, but we cannot measure everything. So that's the point I wanted to make. No, it's impossible to measure everything in the health system. So we cannot. It's just it's impractical, and it's not realistic to think that you can measure everything on any healthcare that health system provide. Still, we can use the concept of value-based healthcare, and again, I would suggest to use the well-being as a concept to guide the action. So because we are doing it, policymakers are taking a lot of actions anyway, and they are also discussing about well-being all the time. So I think we should connect the dots. The second point is about, okay, how do we evaluate value? I very much like this question, as you had anticipated. So we have, let's say in health economics, but maybe other disciplines, we have tools to evaluate different interventions. You can do it in a slightly more narrow focus through cost effectiveness analysis if you're just thinking about health benefits and costs within a budget. So that's one way to do it. But you can go broader. You can bring through other forms of cost benefit analysis or cost utility analysis, you can evaluate the non-health dimensions and bring them all into that notion of well-being. So those tools are available, so we can evaluate value. That doesn't seem to be conceptually a problem. But also, I wouldn't want to say that this is something new. We have been discussing this for the last 30 years. The tools are out there. There is even some convergence across these different debates of making connection with different approaches. So I think that can be done.
Okay, thank you. So, Anna, Christian.
Yeah, value-based healthcare absolutely sort of dictates a data-driven approach, doesn't it? And I think we need to incorporate both patient-reported outcome measures in terms of evaluating value and clinical reported outcome measures. And I think, it's looking at what we measure as well. And, as Luigi mentioned, there are hundreds of things we could measure across a whole pathway or system of care for a patient. But actually, what do we focus on? And that's what we're doing now, is trying to narrow down what we measure, and in terms of what delivers high value. And high value often comes upstream in terms of prevention and things in the patient pathway, and then that leads to an allocative value discussion around where does the system spend its money. And sometimes it's what I want to emphasize as well, this is not just about cost reduction. And sometimes we need to invest in some things upstream to prevent what's coming. And we're doing some work in diabetes, and that's a really good example, I think, where we need to really put some effort into prevention to stop the tsunami which is coming, really. So I think it's about trying to focus on a few measures, but looking across the whole pathway. And right the way from prevention through to end of life care, and what actually will deliver high value and good outcomes for our patients.
Thank you very much. Thank you. Anna, was there anything you would like to add?
Not really. I think thank you very much for this very interesting discussion. I think also the discussion has progressed since the time of our study, but if anybody is still interested in it, it's freely available on our website, and I guess you will share the slides, and I would be happy to continue discussing with anyone in more detail who wants to know more about the Swedish experience, because we continue following it. And thank you all to all the other panelists and the audience for a very interesting discussion.
Thank you, Anna. Okay, so Luigi, your take-home thoughts. You're going to summarize for everybody. What if we take away nothing else in this session? What should it be?
Yeah, I think maybe I'm going to risk to repeat it, but yeah, to me it seems that this concept is useful to use value-based healthcare. But this is not going to revolutionize, to make a revolution in the health system. So I think I would just add it as one additional tool to our toolkit, or to help us to think about policy levers. But I think this is so interconnected with many other things that we're going to do anyway, that is really a way to reorganize your thinking. It's not like one specific policy lever that you can just say, okay, we're going to do this, and that this is going to solve all the problems. I think that's maybe my takeaway point. Thank you.
Okay, as ever, there are no magic wands in any of this. Okay, so thank you very much, everyone, for coming. Thank you so much for such a lively chat box. And we look forward to seeing you in 2 weeks' time, when we're going to be talking about how we regulate the working hours of medical residents in hospitals. So it's going to be a really interesting discussion, really hot topic, and I look forward to seeing you all then. Thank you very much, everyone. Bye-bye.
Thank you.